Now, so briefly
Sir, may
about
I be a
this clinical
volunteer?
session. Yes. Okay, we will go into. Maybe you can do the first session. Before that, I will just give you a brief overview of what is happening in the
Okay,
video
sir. Sure.
session
Thank
and
you.
what is that we are going to do. Okay. See, basically, video session is meant to be a part of the MSK exams only to mimic certain conditions which cannot be brought into the other session, right? So their intention is to have something like an emergency or something like an infectious disease or something like a very rare thing, uh, uh, probably, and something which cannot be kept in an usual clinical session or in a history. Okay, so that is the basics of why they want to have video sessions. So they want to assess you whether you are an fit enough ST3 candidate to handle these situations. Okay, so this could be an emergency or it could be something like an infectious disease with rash, which cannot be kept in real exams or in a clinical session, something like that. Or this could be something a very rare scenario, which again it's not possible to have the case in a clinical session or to discuss that in a history session. It may not be appropriate to do that. Okay. So that's the basics of having the video session. If you see all the video repeats in the past few years, all your video, most of the videos will be in this category. Okay. But then again, there is one exception to this rule. See, there was few videos like this facial nerve palsy video, which was recorded during the COVID exams, when everything was a clinical, even the clinical session was a video exam. Okay, so whether it was through Zoom or any online portal. So they recorded all these examination videos as well. Okay, some RS examination videos, some pneumonia examination videos, some like facial nerve palsy or oculomotor nerve palsy. These are actually recorded for the clinical session, but they are being used as a part of video session. Okay, so that's the reason if you find that there are some videos like which is not fitting into the category what I mentioned, but they are being repeated multiple times in the exam as well. So one typical example is this facial nerve palsy video, which you find that it is not an emergency. It's not something which is uncommon. And there's nothing to have it in a video session for that matter. Okay, but it is being repeated multiple times. So that comes us to the next part of the next clue to the video session is like just please see the repeats for video session because repeats is one thing which will may happen in video session very frequently. Okay. So apart from the scenarios, whatever I have to, also you have to include your repeats for video session because it's going to be an easy session if you get a repeat. The answers, the questions will be very same. For all the video sessions, the questions will be what are you going to expect in the history and what is that you're going to do in examination and give us three differentials based on your observation of the video and then there will be a hint. The hint is a very obligatory hint. They have to give a hint. Okay, so after you give the three or four differentials, they have to say, okay, consider this as well and so how will you manage? Because we cannot talk management about all the three or four differential. We can only talk about only one management or the management of only one differential within those time frame. Okay. So this is how it goes. Okay, so you please see these video sessions or read theory for this video session only pertaining to these matters like emergency, infections, or rare scenarios, plus the repeats. Okay. And I want you to, at target, we ensure that we want students to make sure that they utilize this video session fully and get full marks. Okay, because if you get full marks in video session, it will give you the leverage where sometimes we make mistakes in clinical session. Sometimes the case may not be good or the case may not be cooperative. We are bound to make some mistakes, right? And 6 months is not a good time to do clinical examination itself. We may there a lot of things may go wrong. So this station is supposed to be a station where you get full mark so that you get a good leverage for that other stations so that you can pass comfortably. Okay. And for the questions in video stations, it is 100% from theory, is from only guidelines, nothing beyond guidelines. Okay. So just stick on to the guidelines. Do not read anything beyond the guidelines. It's not required. Okay, they will typically ask one by one as in the guidelines. Okay. If you do not have time, if you are on the last minute of preparation, just see the flowchart alone. That is more than enough. Okay. They are not supposed to ask any doses or anything very particular about any particular drug in the guidelines. They are bound to test your knowledge and your approach for the utilization rather than the minor details, the doses or the routes, something like that. They are not bothered. Okay? Now, before that, one piece of advice I'll tell is always read the stem. Okay, the stem will say that this is a video with audio, and many times we have get feedback that the student has not put the headphone on. Once inside the station, the examiner will not prompt you to put the headphone. Okay, it's all up to you to put the headphone or to just see the video. That is written already in the stem. And sometimes the age is given in the STEM. Say, for example, they will tell that this is a 3 years child or a 4 years child, this is a 1 year child. Again, the differentials may vary depending upon the age, right? So 1 year child, maybe we can think laryngomalacia fasciitis, okay? Say, for example, if it is 6 months child, we will not think of foreign body like that. So read the age as well, okay? So whatever is given in the STEM, it's up to you to read and remember, okay? So do not forget what is given in the STEM and do time management appropriately. You have only 6 minutes and you have three questions like history, what describe the video is the first question, and then what are the questions you will ask in the history, and then they will give you a hint like consider this as a differential, how will you manage? Okay. So basically, few limited questions and everything is on the guidelines, right? Any doubts with this? Is that clear? So this is the underlying principle where they are going to test your knowledge about video station, right? Okay, we will go into the first video. So, doctor, can you introduce yourself?
Yes, sir.
Uh, yes, can you introduce yourself? Can you tell me your name and where are you from? Hello, I'm audible.
Yes, sir.
Yes, may I know your name?
Yes, sir. Dr. Shamsudjaman.
Right. Okay. So this is a video of 6 years female child. There is no audio, right? Okay, so your time starts. Is the video clear?
Yes, sir. Playing.
Yeah. Yes, doctor. Love.
Yes, sir.
Yeah, please
In
go
this
ahead.
video, I can see a girl 6 years old in hospital sitting most probably in pediatric ICU, and perhaps her mom is accompanying her and not in distress and seems to be well grown, and there are multiple bleeding spots present on the lower limbs. So I have some differentials such as this may be a case of meningococcal septicemia, leukemia, uh, viral illness, hemolytic uremic syndrome, septicemia.
Okay, doctor. So, if you are allowed to ask history with the mother of this child, what will be your approach to it?
Sir, I would want to take some history from the mother, onset of the disease, how it progressed over time, and other sites of bleeding manifestations. Perhaps in the video also gum bleeding showing, but not fully appreciated, and any history of drugs and any history of fever. Hello, sir. I am audible.
Yeah, yeah, yes, you're audible. Yes, please continue. Yes. Any other history you want to ask?
Uh, Sir, onset of the disease, course of the disease, and any history of fever, any history of bleeding, and any history of drug.
Okay. So, if you are allowed to examine this child, what will be your approach to examination?
Sir, I want to examine the vitals such as blood pressure, pulse, temperature, respiratory rate. Want to examine the if the patient is anemic or not, and want to examine the urine, color of the urine, and also want to examine the lymph nodes, lymph adenopathy present or not, and also want to examine the uh, um, edema is present or not.
So, you mentioned that you want to measure the blood pressure and do an examination of urine
And
as
also
well.
I want to examine the saturation, pulse oximetry.
Okay, so
Yes,
let's say that would you like to revise your differentials from the most likely to the least likely possibility from your observation of this video for today?
uh, so, this may be a case of meningococcal septicemia, viral xanthem, and hemolytic uremic syndrome, and leukemia.
Okay. So you, as you mentioned that you are about to examine the BP and do a routine urine examination. Say, for example, you find that the BP is raised and there are RBCs in the urine. Would you like to
Sir,
revise the differential?
yeah, yes, sir. Hemolytic uremic syndrome,
Okay.
nephrotic syndrome, acute glomerulonephritis,
Any comments about the distribution of rash?
uh, sir, lower limbs rash,
Okay. So would you like to revise the differential in that case?
henoch-Schönlein purpura, ITP.
Okay. So let's say that this is a case of inoscreen purpura. How would you like to manage this child?
Uh, Sir, I want to take full history, revise the notes, and want to do the urine DP stick test. And I want to, if the uh, I want to take the blood pressure, and if the and I want to involve my senior and senior consultant, and if needed, then I want to involve the pediatric nephrologist.
Okay, lot of things. Yes. Okay. So it's open to feedback. Others can give their thoughts on this video. Anybody else wants to share their thoughts? What went well and how we can improve this video presentation? Yes. You can unmute yourself and you can give your comments.
Uh, Most likely this was a case of HSP, as the rash distribution was it was involving the extensor surfaces, and it was most likely the palpable purpura, and child was well looking, so leukemia is very down the list. There was also edema of the lower limbs, uh, which is also a feature of HSP. Mm.
Point taken. Okay. Others, any other feedback on this video? How we could improve here?
The lower limb, sir, whether this is an edema or it is a feature of arthritis involving the lower limb, that also goes in favor to HSP.
So here there is no particular examination of joint was being shown. So you can include those things in the history. Like you will ask about history of joint pain
And pain abdomen and all.
Yes.
Sir, what they are trying to demonstrate by asking the child to show out the tongue, anything specific in tongue?
Nothing. It is just to say that there is no mucosal
Sir,
bleeding. So
it is probably, sir, being shown to demonstrate that there is no bleeding.
no bleeding in the
The gum and the tongue is free of any bleeding.
Yes.
Okay, okay.
Okay, others, any critical opinion on this video, how we can improve? Feel free to talk. Right. And for the presenter, my feedback is you started off well. Actually, you described the video in a proper way, like the setting, like the age, and you started about the rash, everything perfect. Okay. Maybe if you have a larger video, if you think that you will forget some part of the video, you can describe like in the beginning of the video, in the middle of the video, in the later part of the video, so that you will tell that they are trying to examine the oral cavity and it's about normal, and then they are focusing on the limbs where the rash is predominantly on the extensor aspect, and they are talking to the caretaker. Okay, can tell caretaker if you're not sure. Okay, whichever information is not given, you do not assume and tell mother or something like that. You can tell caretaker. The probably the doctor is asking questions to the caretaker, and it is being shown. Right. Okay. There is one thing. Actually, you did the description video in a very proper manner. You have to do like this. Like you have to tell the setting first. Okay, and then tell about what is the starting thing shown in the video, and then the middle what they are showing, and then anything important in the end they are showing. Okay, so you will tell that you will describe the video basically in terms of like you are seeing a case in front of you. Okay, you will tell in terms of the setting, whether child is in distress and in dysmorphism, okay, any devices around. All these things you will describe like in a clinical station, and then you will tell about the video. And if it is going to be a video like this, you will tell the beginning, middle, and end. If it is going to be event, say for example, some other event is happening, you will tell how the child is before the event, during the event, and after the event. Okay? That's how you will describe the video, right? So after the video, the next question is what are the questions you will ask in history, right? So essentially, the history part of any session for the or the not only in video or the matter in even on routine clinics. The history is meant to focus on only two things. One is to put forth questions which will bring about the diagnosis, or to put forth questions which will give you a complication of the probable diagnosis, right? So this is the basics of history taking, right? So you will think of all those questions which you will put in a child who's having rashes like this, okay? So your differentials are fair enough. You told leukemia, you told meningococemia. These are all very good differentials. Actually, you need to tell those differentials down the list in this video and tell these are pointer against. Like, say, for example, there is no mucosal bleed, there is no signs of any nodes or any swelling shown anywhere else in the body. The child is not sick. Okay, so these are the few points you will tell. Okay, because essentially, MRCP exam is ensure that you are a safe ST3 candidate, right? So you need to have some bad differentials for that video, maybe, but you can tell it down the lane if it is not fitting. But you can tell, however, these are point against leukemia, these are pointer against meningococemia. Okay. So you will put forth all those questions, okay? Whether there is any constitutional symptoms, whether there is any sort of like history of drug intake, okay? Any history of fever with rash, and then you can again put questions like abdomen pain, joint pain, all these things, any blood in urine, okay? Any decrease in urine output, all these things you can put for HSP as well. Okay. So again, one thing is if you think you will run out of questions in the history, you can think like again in the same like the history of present illness, past history, maybe about if it is relevant, you can put forth questions in the vaccination, you can put forth questions in the family history, all those trends. Okay. You can frame your history taking in these order so that you will not miss any part of the history. And essentially, you will think about only questions which will give you an answer for the diagnosis, or questions which will give you answer for the complications of the probable diagnosis. Okay, you can think in that aspect so that you will frame your questions continuously. At no point of time, do not give a empty pause in a video session. Okay, that will give room for the examiners to ask more question, and they'll give you a comment on the ultimately, and that the candidate require a leading to answer question, or he requires a probe to answer question. Okay, so they will give a comment like that, and they may reduce 1 or 2 marks for that. Okay. And then next question about examination. Again, here again, you will tell about you will do the basic things. Like in a clinical session, you will do 4D and then vitals. And then you will tell which system you want to examine probably, and any bedside test you want to do for this case. Okay, here the bedside test I would focus on this. One is this blood pressure recording. Other one is this urine recording. Okay, urine macroscopy and urine microscopy because that is important in IgA vasculitis. And then the hint comes here. Here because you have told me about leukemia, other things, then I need to give you some hints to come out the diagnosis, right? So here,
fish. Does she have it?
okay. So please, others, mute yourself. So what they will tell is in this scenarios where the candidate require a hint to arrive at the diagnosis, they will reduce 1 or 2 marks and they will write in your feedback that the candidate requires multiple hints to come at the differential diagnosis. Like that, they will give it some remarks on your performance, right? So after they tell about the hint, the only question is how you are going to manage, right? So management divided as investigations and treatment. Again, investigations you can divide as investigations which is for the diagnosis, and investigations supportive investigations. Investigation here for the diagnosis, maybe you can tell about the slide test for the rash, as well as you can tell about routine urine, and you can tell about urine albumin, urine PCR measurements, and then you can tell about, if required, you will go for a skin biopsy. If it's required, after discussing with the consultant in a doubtful cases, you can go. Otherwise, it's a clinical diagnosis in general, IgA vasculitis. Right? And again, after coming about the investigations, the treatment part should be like, again, you will tell if it's going to be an acute case, you will tell in terms of admitting this child, stabilizing this child in terms of ABC or resuscitation, etc., etc. If it is going to be a chronic case, say for example, sometimes a facial nerve palsy, if some chronic case is given, you will tell you want to review the old records and what investigation is already done and what is that you want to plan for this child. Okay, and then you'll tell about the team. In both these scenarios, you tell about the team which is required for this case. So here it is essentially a periodic consultant, and in few cases you want to have a referral to pediatric nephrology or a pediatric rheumatology team, okay, depending upon the case scenario. And then you can tell what is the treatment you can just give a broad outline when do you want to give a nephrology referral for this case. Okay, so that's how you go with the management plan, and ultimately take your management till the counseling part. So what you will tell to the mother and what is that you're going to monitor in the follow-up. So you will advise for home BP recording and home urine dipstick monitoring, right? So you tell about that, and you will counsel against few things like avoiding NSAIDs or avoiding dehydration, all those things, right? And then you will tell about the follow. Okay. And if you have gone that forward, that will take your time of your 2 minutes of management, right? So basically, keep talking till your time comes. You do not give any empty pause. Then if you give empty pause, then that gives a room for examiners to ask some questions like, tell me some indications for nephrology referral in this case. When will you do a GP follow-up or when will you do a nephro follow-up? Right? And then again, everything goes into the final aspect of guidelines. Okay. So keep talking till your counseling part of the management. The way you finish off everything on time. Right? Is that clear? So
Yes,
if, say for example, they may ask one or two complications with HSP, then you can tell about interception, you can tell about this nephritic syndrome presentation. In male child with arthritis can be an issue. Abdomen pain. Okay, these are a few things. And indications for admissions they may ask. Okay. So arthritis involving two or more joints, severe abdominal pain. Okay, then again arthritis and somebody who's have a GA bleed or proteinuria. These are all a few indications for admission, right? Everything is there in the guidelines, nothing. So do not, and once again, for all the answers, please stick on to the UK guidelines, okay? Do not tell from your experience or from your national guidelines. Do not go, just stick on to the associate guidelines. Is it clear?
yes, sir. Thank you, sir.
Right. So your differentials are good as an S3 candidate, but always tell with points favoring and point against. And if you have something very typical, go for that as a first differential. Okay. Right. Okay. Others, any doubts with this station? Everything clear? Good. So who wants to do the next video? So open to everyone and volunteer. Nobody wants to do this one. And I want to tell this whenever you have an opportunity to practice with your friends or anywhere in whichever group you are. Please feel free to make mistakes, okay? Because those are the mistakes you will definitely not do in the real exams. And nobody is judging your knowledge or judging your performance here. Okay, it's all about tuning yourself for the real MS exams. Okay? So feel free to make mistakes. Everybody will make mistakes when given a scenario in an emergency situation. But we are here to learn ourselves and refine ourselves. So do not have any hesitation in making mistakes. Okay, we are not judging you here. It's all about training yourself and adapting yourself for those 6 minutes, giving a performance and coming out with your marks. That's all. Right? Shall we go to the next video? Somebody is ready. You can go on to the next video. Yes, please volunteer. I'll tell you the next one is going to be more easy. Please, you can do that. Yeah, come on, unmute yourself, one of you, and you can try it. Please do.
Yes, sir, I can try, sir.
Yes. So I'm not reading the chat, so please do
Yeah, this is Balaji,
Backup
sir. I
also.
can, yeah.
Okay. Okay. So this is your stem, right? I'll go on to the UV. Are you able to hear the audio and video?
Yes, sir, I can hear.
Right. Yes, Dr. Balaji, you can start.
I just want to confirm age alone. Is it 8-year-old boy or 8
So
month?
once you are into the STEM, it is 8 year.
Okay.
8 year.
Okay. Yeah. I could
Is
see
it
that.
look like 8 months?
Illa sir, I just M for
Okay, fine.
that put. Yeah.
Okay, fine. Male child,
Yeah.
right? Okay, go.
So this is a 8-year-old male child, probably in the emergency setting, who is on oxygen nasal prongs. I could see that the child is having tachypnea with suprasternal subcostal retractions, and he's also having expiratory sound, which is looking more like expiratory wheeze or a strider. He is in impending respiratory failure, is my impression. Probably um, secondary to a wheeze or a LRT.
Okay. So what are the questions you would like to ask in the history if you're allowed to talk with the mother of this child?
I would ask the mother about the onset. Is there any fever history is there, and any previous any history of foreign body aspiration, and also events leading to the current situation, and also any previous history of nebulizations. Then drugs, any preventive therapy is already taken.
So if you're done with the history, if you're allowed to examine this child, what will be your approach to examination?
I'll start with ABC. Look for airway breathing circulation, and want to know whether this child requires immediate intervention. Um, and then I will go for systemic examination. I would like to check his saturation. I would like to check his BP. I would like to check his heart rate, and also whether the child is in shock. And in systemic examination, I want to auscultate for air entry, added sounds, and also cardiac examination I want to do, and any hepatosplenomegaly.
So as you examine, because you know that you want to examine for shock, let's say that this child is in shock, and on your respiratory system examination, the air entry is present bilateral and it's clear, no added sounds. Do you like to revise the differentiates?
I would think of if any history of fever is also associated, any cardiogenic shock I want to rule out. And
Again, you examine the cardiac resistance, they look normal, no added sounds, no noise.
any dehydration, any history of hypovolemic shock, or it is silent chest, which is a very severe respiratory distress.
So I mentioned that there is air entry bilateral. You mentioned about dehydration. So we like to think of any other differentials at this point.
Diabetic ketoacidosis, DKA with
So let's say that this is the case of diabetic ketoacidosis. I would like to do your management.
I would like to categorize the DKA here. So I would want to do a investigation wise CBG, blood gas, and accordingly I will to start him on hydration, insulin therapy.
Yes, please proceed with your management. Anything else you want to do?
I want to stabilize the child first. So if he's in shock, I want to give fluid resuscitation, followed by fluid calculation for the diabetic ketoacidosis and insulin infusion along with that. And also later I want to know whether it is type 1 or type 2, and I want to know for C peptide levels and
Yes. No, no need to discuss with the high school.
I want to titrate the insulin based on the sliding scale and give insulin infusion along with appropriate hydration. And also I'll ask about any previous history of similar episodes for the child.
It's open to discussion. Boss can give your feedback on how we can improve here in this routine. Yes.
Here, you have mentioned that the child is in shock. So we could have managed it first by correcting the shock, first of all, by giving a 10 ml per kg bolus as according to the guidelines, and then go on with the rest of the treatment. That is correcting the fluid deficit and appropriate insulin therapy. And initially, when he was describing the case, the type of breathing was actually deep acidotic type of breathing. So was more specific of like Kussmaul's breathing that could have been added. And in differentials, so we can say that if we are speaking that there is Kussmaul's breathing, our first differential would be DK. But apart from DK, we should also consider pneumonia and, as he mentioned already, lower respiratory tract infections. And because we don't know whether there is this history of fever or not, and also foreign body could have been considered. I think this could have been the differentials. So if we would have considered different diabetic ketoacidosis, then the history would have been, apart from fever and foreign body, which he has already appropriately mentioned, foreign body history would have been whether he had any previous episodes in the past, similar episodes, as has already been on therapy or not, and whether he had missed any dose, and what were the events, whether there's any illness, or specifically, usually we see illnesses like minor illnesses or UTIs, which are common in diabetic cases, so that we could have asked. And since how many days, and then again later on, like since how many days, whether it is a type 1 diabetes mellitus, and how many, when was it first diagnosed, that could have been briefly asked. And in examination, we would also do, like he already mentioned about respiratory and cardiac examination and vitals, that was appropriately mentioned. We could also have added CNS examination to look for signs of raised ICP.
Okay, Doctor. May I know your name, Doctor?
Eman.
Thank you, Doctor. I think you made my job easier. So essentially, she has mentioned that you have to divide your history into present illness, past history, and then the other part of the history. So in present illness, we are putting for questions to get your differentials, right? So this is a clearly rapid and deep breathing, is it not? So this is a typical acidotic breathing, rapid and deep. So your thoughts could be here, it could be still a pneumonia is still possible. I don't, because unless you examine, we are not sure about that. It's still possible. But apart from that, okay, you can have other things like even shock will have an acidotic breathing, any dehydration, so diabetic ketoacidosis, and more importantly, renal failure and any poisonings, right? So all these things, including urethral paper poisoning, all those things can cause deep acidotic. So you can have those differentials. So if you think of these differentials, then you will put your questions accordingly to ask questions. Whatever she has mentioned, to put forth to get the etiology of that. And then in the past history, any similar episodes or any instance, or any anything else in the past which is be giving a clue to present diagnosis. So that's what the overall crux is here. An examination. So when you came to this RS and CVS, everything is normal, then again, that's a clue to you to get to the differential, right? So again, here the examiner in your feedback will mention that the candidate required multiple prompts to arrive at the differential. That's how they write this. Okay. So they will reduce these marks for that accordingly. So So when the and one good thing is when the you should be in a state of mind to get the prompt in the case that you have missed the video, and then adapt yourself and come to the differential. Okay, so that you did beautifully. When I told that this is normal or this is normal, you came into dehydration and then decay. Okay. So in the heat of exams, we should not in a question that when the examiner gives the prompt, even then if you're going to miss the differential, then it's going to be giving a very low mark in that station, right? So once you come to the definition of DKA, so the questions will be straight from the DKA management only. Okay, nothing new here. You just click onto the protocol, the flow chart given in DKA. Okay, they will do investigations depending upon if it's a first episode or it's going to be a content. So they will do this ABG and they'll do this hourly CBG, urine ketone, serum ketones. Okay, and if it's going to be a first episode, they will also do the celiac screen, GAR antibody, TFT, as well as CPP levels. All these things they will do, and they will do this HbA1c, and they will look for any foci. Okay, so basically blood culture, urine culture, and LP. If there is for meningitis, they will again do LP as well, right? And management, stick on to the hints given. Okay, when the examiner says that there is an error entry, do not go again back into silences. Okay. Here again, the feedback will be like the candidate did not get the prompt. The prompt was given, but the candidate was not able to understand the prompt. Okay, so do not go back again. Whatever is mentioned. Okay, if there's a shock is mentioned, then you have to do this 20 ml per kg of ANS. Okay, and then your fluid correction depending upon your percentage of dehydration. You will say that's 5%, 10%. Then it correct it over 48 hours, right? So you'll give this normal saline at 20 ml per kg in the initial 1 hour, and then you will just dehydration correction over the 48 hours, and then you will start simultaneously insulin after correcting the dehydration. You will start this 0.15 to 1 unit per kg per hour, and then you will go with insulin infusion. And your target is not to reduce the blood sugar. Your target is to correct the acidosis. So even if the blood sugar is coming down, you will replace the appropriate DNS, and then you will still continue with this insulin infusion until the acidotic part is corrected. And before you start the infusion, half an hour before, you will go for subcutaneous insulin. Everything is there in the guidelines. I'm not telling you anything. It's there in the guidelines. Stick on to the guidelines. They see in general wherever there is a flow chart is given in the UK guidelines, they will ask what will you do first. Next, what will you do? Next, what will you do? Like that, they'll keep on asking you, probing you accordingly. Okay, so just tell the first step. I will do this. Okay, start correction the dehydration. Then I will start avoiding insulin. Okay, then giving correction or 48 hours, and then before stopping, what will you do? So before stopping, I will give insulin because subcutaneous insulin, and then change over to subcutaneous injection. That's how you tell. Okay, and here when you have time, just go with the management. Okay, DKA management is not about just actually. You have to counsel the parents. You have to tell about what has address the etiology. Probably if there is any missed doses, you will ensure for compliance. It's going to be a lifelong issue, right? So you will talk about heavily about the counseling part of these things, right? And even pneumonia, you can have a differential. In upfront, you are going to tell pneumonia. Then by tell pointer against, we have rapid and deep breathing. And then the examiner mentioned that there are no added sounds. So I will have to keep pneumonia down the differential. Right. So I think some amount of fine tuning you may require, and that will help you in getting the guidelines. Okay. So if you read the guidelines, I think everything will get easier for you, Dr. Parasi. You just stick on to the guidelines, do not read anything new, or it is not delve with the Indian protocol or whatever it is. We will just stick on to the UK guidelines. Clear? All right. Any doubts with this?
Sir, what you said about air entry, bilateral, it was present or not?
Present, present. I told air entry is present and there is no added sums. I'm just
Okay,
giving you,
okay.
giving him some prompts so that he will come to the differential. Because he was mentioning pneumonia, I was mentioning there is no problem with the air entry or no added sums there. Right? Any other doubts with this? Yeah. Which, so shall we go to the next video? Somebody wants to try, you can
Sir, if patient is in shock, how many times we can repeat the bolus?
Generally, as per the guidelines, you'll get 20 ml per kg. It's first bolus.
If 20 or 10 is very confusing. Some says 10, some says 20.
Maybe we can just refer to the guidelines. To my knowledge, I think it is 20 ml per kg as per the UK guidelines.
Okay, and how many times we can repeat it?
It's usually once, okay, and then you'll go with
Okay.
infusion.
And then we'll go for?
48 hours correction. 48 hours.
Oh, okay.
Right? If there is no shock, you will again go into the usual correction without bolus. Okay. If it is like a shock, you will go for 20 ml per kg. If there is no shock, you will go this 10 ml per kg for half an hour, and then the hydration correction, depending upon the percentage of dehydration, that is 5%, 10%, you will give correction over 48 hours. Right? With NS. The choice is NS. Mostly. Right? Any other doubts with this video? We'll go to the next video. Who wants to do this? Who wants to try? Come on. One of you please volunteer so that we can have some discussions before we close. Can I cover some names if you want?
May I try again, sir?
Yeah. Yes, doctor.
Dr. Shamsudjaman.
Yeah, yes. Nobody else is there, then maybe. Is that okay? Anybody else wants to try? Okay, we'll go with you, doctor. Thank you. What's this one? Okay. Right?
Yes, sir.
Assalamu alaikum.
Sir, age is 16 months.
16 years. Female, female, okay. Let's have this way. 16 years, female. Right?
16 year or month, sir?
Yes, yes.
Oh, year. Okay.
Shall we start?
Yes, sir.
Yeah.
In this video, I can see a 16-year-old girl, perhaps in home sitting or outpatient department sitting, apparently well grown, not in distress, no device is attached, and showing his both hands, and there are hypopigmented lesions in both hands, along with multiple bleeding spots and scratches.
Right. So, what are the questions you would like to ask in the history if you are able to talk with this teenager?
I want to ask onset, when it first appeared, and how it progressed over time, and any history of drug, any history of fever, any history of itching, and any history of decreased urine output.
Okay. If you're done with the history, then if you're allowed to examine this teenage girl, then what will be your approach to examination?
Then I will examine the baby, a child, want to take the blood pressure, vitals, and pulse rate, respiratory rate, and also want to examine limb adenopathy is present or not, any, and want to see the child's urine color, and also want to take the dipstick test of the urine, and also any limb adenopathy is present or not, any mucosal bleeding is present or not.
Okay. So, would you like to give a differentials considering this age and
Yes, I have some differentials such as it may be immune thrombocytopenic purpura, drug reactions, and also maybe self-induced trauma, self-induced injury.
okay. Any other differences you want to have in your list?
Sorry, sir.
Any other differences you want to have in your list? Right. So you mentioned that this could be a drug induced lesion or it could be a self-injury, right? Can you tell me some
Yes.
points favoring or point against self-injury?
Yeah. Points in favor: female child, 16 years of old, and also there are multiple lesions. Some are healing, and also some are new, um, and all in the accessible parts, only in the both hands.
Okay. Okay, doctor. Okay, let's say that this is a self-induced injury. How would you like to do your management?
Yeah, I will take the full history, and also assess, and also involve my senior consultant, and I will also um, do the proper counsel of the child, and also involve the pediatric psychologist. Uh, uh,
Okay. So any part of the history would you like to focus on, considering that this is a self-induced injury?
Sorry, sir.
Is there anything in the history would you like to stress upon while taking history?
Yeah,
Consider this as a self-induced
I
injury.
want to take history about her friend, friends, and about any history of any drug history, any history of sexual assault, or any history of sexual and any history of depression.
Okay, doctor, thank you. So open to discussion.
Sir,
Can
why
you
it
admit yourself?
Sir, why it can't be psoriasis under treatment because the well-defined plaques might be due to like this due to treatment topical?
So would you like to say this as a plague-like lesion or it's like macule? First. So one thing is I would not describe this as a plague-like lesion. One, and the typical plagues in psoriasis is more over the extensor of the elbow or wrist or in the knees. Okay. Although there are better type of psoriasis which can form in dewdrops, this is not that morphology doesn't go into the gritted psoriasis either. And one striking point is, would you like to say that all these lesions are of almost similar size and similar shape? What do
Are
you think
these
about that?
cigarette lesions like
Yeah,
caused by
exactly.
cigarette burns?
Exactly. Okay. So one or two are active lesions, which is our new burns. Everything else is an old cigarette burn just healed. So do you find there is a pattern here? Okay, everything is almost same size and shape. This doesn't come with psoriasis. And it is all there only in the extensor aspect, which is reachable for an self-induced injury, right? So you see this abrupt transition into the middle side. It's more over the side where it is easy to keep it from the approach to the other hand, right? I think that clears it out about psoriasis.
Sir, pityriasis versicolor with self-induced injury may be
Yes,
differentials.
yes, psoriasis vesicular could be a differential here. But again, you see the size and the shape. Okay. One. And typically the face is not shown here. One. And the morphology of the lesion. Again, there they will have this fine scales. Here it looks like more like a healed scar, right? You can have the differential, but you can tell points for and point against.
Yes, sir.
Definitely, this is not the central. The red one is not definitely Pitaceous vesicola, right? And obviously, there is no much fine scales visible here, although the scales can be very fine in Pitaceous vesicola. And most importantly, the lesions are of almost same shape and same size. And it is all distributed in the extensor aspect, which is more reachable, right? So my comment to you is like, again, your description of the video is perfect. Like you described the setting and you told that something is shown on the extensor aspect and you mentioned about the lesions, everything is fine. Okay, right. And history again, if you have had this differential in mind, then see, even otherwise, I will tell you, whether it is an institution or video station, if it's an adolescent, please focus your history on the heads component, right? So you mentioned in terms of friends and sexual activity. More so over, there's a terminology for that, right? So there's a heads in history, right? So home, education, okay, then drugs, okay, then again social media, okay, sexual activity, all these things. Okay. So focus on the health component in the history. That's one important thing. And in your management, definitely you involve a consultant, which you mentioned. And moreover, the approach here should be non-judgmental and non-confrontational. Okay. Here we will not go straight forward and say that you are doing this. Okay. So here you open the statement in a more relaxed atmosphere, in a non-judgmental way and non-confrontational way, telling that I do see that your skin is under stress currently, but we need to do a few tests or we need to do more questions and more interview with you to get what is happening this. Right? So like that, you will go in a slow manner and preferably you involve here your CAMP services, right? Childhood and adolescent mental health services team will be involved here. Your consultant will be involved here, right? And the better term to use here is a dermatitis artifacta. So, or could be a factitious disorder, right? So, factitious disorder is a new term to dermatitis artifacta. Um, Meaning it is not something which is a broader term to have somebody who's having exhibition in a borderline personality. You call it as a factitious disorder. right? So here basically it will be more about the counseling part, cognitive behavioral therapy psychologist role, and finding that if she's in a safe atmosphere at home, at school, and with her friends. So that is one thing. And if there is any concern with your safety, then the visual safeguarding protocol will be taken care. Right?
Sir,
Yes,
I
sir.
have a doubt. Apart from head's history, what should be the main history that we have to ask in this case once we have
For
given our
any
differentials?
for any rash, always start with how it began, how it progressed, okay, and what makes it worse or what makes it better, how long it is there, any history of similar rashes in the past, was there any associated fever, was it started after any intake of any medicines or any drugs, right?
Okay.
These are a few questions for any rash.
Okay.
Okay. Again, one differential you can here give is drug rash. Okay, drug reaction can be see. I will tell you for any rash, you can tell drug reaction as a differential. Nobody can refute that. Okay, but you can tell again, point against this, it is all focused on one area, extensor aspect, and it is all like almost similar lesions.
Sir,
So
sorry,
these are
sir.
the
What
point
you
against
say for F3 rash? What I will put one differential.
drug
Drug. Okay, sir.
rash.
Drug reaction. Okay, okay, sir. Thank
Yeah.
you.
Yes, somebody else is asking another question. Yeah.
Sir, what are the differentials that if 3 or 4 differentials are required in this one? Dermatitis
One thing
artifacta is
is
number one.
dermatitis artifacta is one, and drug rash is maybe second one. Maybe you can tell eczema. There are some scratch marks as well. If you see in the video, there are some scratch marks. You can tell eczema. You can tell burns.
Okay.
Burn
Thank you.
wound. If you want to tell psoriasis, then again tell psoriasis and point rackets. If you want to tell vesicola, then tell point rackets. It's not always necessary that you have to give 3 or 4 differential, but generally we tend to limit your differentials to around 2 to 4. Probably 3 is a good number. And always tell the most likely differential upfront. Okay? The most likely differential for that video upfront. Maybe the second close differential you can tell as a second one. And maybe you can tell always one bad differential. Depending upon the case, if it permits, you can tell one bad differential. That is to ensure that you are a safe ST3 doctor. That's the whole objective of MSCPC is to ensure that you are a very safe ST3 doctor. So we can tell one bad differential, but if it is fitting, you can tell it, or if there is a pattern against, you can tell. However, these are the things which is against this differential. Like for example, in the first one, he mentioned about meningococcemia. You can tell that, okay, you can tell leukemia, but the child is well looking child.
Sir, can we put a scabies differentials here?
Scabies, yes, you can tell scabies differential because you see some itch scratching marks and itching. I mean, some linear scratch marks are there. But again, you can tell point against. Scabies 16 years. Okay. Yes, you can. Maybe down the list you can tell.
Sir, can we say vitiligo also or no?
Vitiligo is depigmentation. This is not depigmentation, right?
Okay, thank you, sir.
So basically, the history is more into the heads component and the management is more in the childhood and adolescent mental health services with your consultant. Okay. And it should be non-judgmental and non-confrontational. That's the core of talking to an adolescent as per the university research. Right. So, any doubts with this? If somebody is there, we can go for another video. I have one more video. So done with this, we can stop. Just one minute past. I have one more video. Somebody wants to try, can go with that. Let's stop here. Somebody else wants to try one more video.
I would like to try the next videos.
Thank you. 11 is male child. Okay, 11 years, male child. There is no audio. Yes, shall we?
Yes, sir. This is 11-year-old male child, probably in a hospital setting, examined by a doctor with right knee joint swelling. In this video, the doctor seems to be examining the joint swelling for tenderness, warmth, and fluctuation. This swelling seems to have fluctuation and there's also restriction of joint movement. The other leg, the left knee joint appears normal. There are no devices attached, and he appears a bit underweight or malnourished.
So if you're going to ask history from this
My first history,
11 years male child, what will your approach? Yes.
I would like to ask if there's any history of any trauma, any history of any other swellings otherwise in the body, such as neck swellings or any abdominal distension, any bleeding history. And I would also ask if there's any history of any fever, any history of bleeding in the family, any history of any apart from long-standing fever with uh, other systems with any other infections like previous history of throat infections. And I would also like to ask if there's any pain and difficulty in movement, which is obvious here, I think.
So if you're allowed to examine this boy, what will be your approach to examination?
First, I would like to examine the joint involved. In the particular joint involved, I would like to examine for the any warmth, tenderness, restriction of movements, and fluctuation or not. And then I would also like to examine all other joints. And then also I would like to look for any lymphadenopathy and hepatosplenomegaly specifically. Then I would like to do and pallor. And I would like to do a systemic examination of cardiac system if there's any murmur involved, and I would like to look for hepatosplenomegaly and any rashes over the skin, fatigue or purpura.
So from your observation as you give for today, like what are the differentials you need to think of?
My differentials would be since it is a single joint swelling, probably as if it is a single joint swelling. First thing I would think of any septic arthritis, or since it is looking a very large swelling with also fluctuation, my second differential would also be hemophilia. If there is any history of bleeding in the family or previous history of bleeding. Apart from that, there could be arthritis, reactive arthritis also could be there, and post-streptococcal arthritis could have been there. But it's mostly single joint. Single joints, I would focus more towards septic arthritis and hemophilia. And lastly, my also one differential would be malignancy.
Okay, let's say that this is a hemophiliac joint. How would you like to manage?
Since it is hemophilia, first I would like to know whether it is hemophilia A or B. Depending on that, I would like to give factors to correct the deficiency. So I would like to give, if it is hemophilia A, 50 to 70 international units per kg factors. And till the joint restriction is improved, I would like to give it on alternate days. Apart from that, because there is swelling in this joint, we can give rest, ice, compression, and elevation for this. Supportive management should have been done. I would also like to involve the blood specialist, that is the hematologist. A multidisciplinary team approach should have been done. So pediatrician with the hematologist on and also discussion with physiotherapist.
Okay. Any specific advice you want to give to this?
Yes, we have
as
to
well as
advise
caretaker?
them to prevent further traumas, and we also if it is hemophilia previous history of similar I would have asked. In the advice would be to avoid contact sports.
So it's open to discussion. Any comments?
Differential diagnosis.
Pardon?
JIA.
Jay, okay, she mentioned reactive arthritis. Okay, that's part of it. Yes.
And sir, TB arthritis.
Septic arthritis, I think she mentioned that TB can be part of it. The comments overall, other comments.
Sir, I have one doubt. Here, there was no erythema in the joint, I think,
Okay.
and there was
No
fluctuation.
obvious
So
erythema.
no obvious. So I think did not mention that. So I would if there would have been erythema with fluctuation, septic arthritis should have been first differential. So I think since there is no obvious erythema and also fluctuation and large joint swelling, so the first differential could have been hemophilia here actually.
You have a differential first or second, then it's not a big deal.
Okay.
I think your performance here is like you get full marks for registration. Okay, so because there are no prompts here, you had a good history. But one point I felt that your history was more into malignancy and reactive arthritis, but ultimately the differential you gave hemophilia. I don't know. I think the transition came as you are thinking while presenting, or where it happened.
No, sir. My first history was history of any trauma. So that was for hemophilias.
Okay, fine. So most of them, again, family history is one, and then there's any past history of similar episodes, recurrent joint swelling is. So, so that's the reason when I opened this discussion for today, I told that you divide your history into multiple parts so that you can remember at least put 4 questions which will come in that part. So if you remember that we have to include family history as well as past history, then maybe you can think and put appropriate questions for that video in those parts. So simple trauma, okay. Trauma is again a good point for hemophilia. Right. Otherwise, also even traumatic, post-traumatic hemoarthrosis can be happen in single joint. It is also still possible. Okay, so here it is only hemophilia was the only main thing. The joint, if you have seen hemophilia joint, it's a typical video of a hemophilia joint. Okay, and one more thing is there's a obvious wasting, right? So you find there's wasting above and below. That is also there, and as well as the limb is in a somewhat a partially flexed attitude, right? That's a point of optimum comfort whenever there is a swelling, there's a pain, the knee goes into a partially flexed attitude would be a child comfort. It's uh, the attitude of the optimal ease and comfort for that joint, right? And management, I think you mentioned about the factor. So everything is factor correction here. So you will not wait for until you start doing the factor. If it's a known case, I might be like, hey, you will do correction as per his previous. You will go into the records, see his severity, whether it's mild, moderate, severe. Then you do. I think for dependent joints, it is 100%. Correction is required as per the liquid protocol. If it is non-different, I think it is 30%, around 30%. So you calculate that divided by 2 and then go for correction for factor 8. So that's the important thing. And as you mentioned, you will give it alternatives 3 days in a week. But severe hemophilia, prophylaxis is a standard of care, not you don't give it after the video, you give it prophylaxis. There are other actions as well, like fever and recombinant cortisol, etc. And advice, as I mentioned, avoid contact sports, avoid IM injections, avoid NSAIDs, avoid intramuscular painkiller injections, and having this bracelets and counseling. These are 3 things, and constantly the family members. This is going to be long problem. So all these things will be in your management. Overall, more than satisfied with this approach, and you will get full marks for this today's session. Any doubts with this video? She covered most of the things.
Sir, I have a question. We know this is a case of hemophilia, but sir, how if some other video come, we can say it's a case of transient synovitis or reactive arthritis? Because in septic arthritis, child will be like ill-looking and there will be arrhythmia, anything. But how differentiate between reactive and transverse synovitis?
You will not be able to differentiate just by observation of a video without a novel. Not possible. You can have those differentials. Very well, point taken. One thing is transient synovitis predominantly involves hip. Okay, that is one. And usually it's less than 5 years child and there is a preceding URL. And most often it's going to be a self-limiting condition. Okay. Reactive arthritis is a good differential. Reactive arthritis do cause some large joint swelling and it is definitely acute subacute presentation. That may happen in that way. Okay, so that's the way. That's why you have to give 2 or 4 differentials, and then the examiner will give a hint before you proceed with the management. Okay, so after the hint is given, you stick on to only the management of that differential. You won't again venture and go back into it. So
Okay, sir. So
me
what will
making
be the hint for reactive arthritis? Like before any
they,
illness
they will
history?
tell the differential. They will tell the differential. You are giving differentials, right? She mentioned about JAE, reactive arthritis, and trauma, and then I think she mentioned septic arthritis. They will tell you, consider this as a case of septic arthritis, how will you manage? Consider this as a case
Okay.
of reactive arthritis, how will you manage? Okay. As per the MRCPC exam pattern, they have to give a hint. Obligatorily, they have to give a hint. It's essentially, it's not optional for them. The examiner has to give a hint. And then the manager will proceed in accordance with the hint given.
Okay.
Okay, because we cannot talk about the management of reactive arthritis, management assets, and management of all in one go in 2 minutes. It's not possible, right? So they will definitely give you a hint. Don't worry. Okay, it's a part of their exams. Did I clarify your doubt? Did I make it clear? Is the doubt clear, or was still not convinced? Okay,
Yeah, okay.
right. Any doubts, or shall we stop?
Sir, if they show both knee joint soilings,
Hmm.
so then we like in septic, we can also say septic and reactive. Or usually one joint
If
is involved in septic and reactive.
if you have more than one joint involved, then the reactive arthritis may go upfront compared to septic arthritis. That is one. Okay. And again, nothing prevents infection in two joints. Okay, if it is hematological spread, it can happen in two joints. But the likely possibility of reactive arthritis is more. In general, if it is going to be single joint swelling, in pediatric, the top definition is septic arthritis. Okay,
Okay, thank you.
right. All clear? Any doubts so far in whatever this video we discussed for today? Right. And stop talking about it. The recorded session will be shared in the group. And thank you all for participating. Good luck.
Thank you, sir.
Thank you.
Sir, will you upload this video
Yeah,
anywhere?
I think we will. Yeah, we will upload in the in our chat.
Okay, thank you.